welcome to your first session after lunch. I hope everyone is well fed and watered and isn't going to get too postprandial. My name is Dr. Rachel Bornberg. I'm a consultant anaesthetist at the Royal National Orthopaedic Hospital, and I'm orthopaedic lead for PQIP.
And I'm Sandy Jackson. I'm an academic clinical fellow in Southampton, but I also work with the central PQIP team, and I'm an anaesthetic trainee during my clinical life.
So we're going to crack right on with some best practice evidence reviews, and our first speaker is Charlotte Taylor from Guy's and St Thomas's, who's going to talk about diabetes management.
So I've been introduced, you know who I am, where I'm from. The other thing you don't know about me is I'm actually type 1 diabetic, so I tick the patient box as well. So there's not a huge amount of evidence, new evidence on what to do. So it's a review of what we know and some specific bits about things that I think are important. So as we all know, there's a diabetes explosion. It's a bigger and bigger problem. The vast majority of our patients are type 2s, but there's quite a significant population in the country with diabetes. And actually, it's overrepresented within the PQIP population of 13% in this is the 17-18 report, because that's all that was available when I was writing this. And the other important thing is hyperglycemia, regardless of whether you've got a formal diagnosis of diabetes, is a risk factor for complications in the perioperative period. So this is why we're hunting it out as part of improving outcomes. That magic 8.5, so there's some figures from the report. So that is the recommended limit for the HbA1c for elective surgery. There's 69 in new money, so we've got to go move on to getting our new figures for that. The next one to look at is 90%. That's the 90% of patients who with an HbA1c were presenting of 8.5 or more were presenting for elective surgery. How many did we measure it in? We all should know that figure now. It's 69% in the last report. And we've made it a bit better. Oh, it's now 72%. And then 20% of PQIP patients with poor control are still going through for surgery. And that's going to potentially have an impact on their outcomes. So where do we get our information on what we're doing? We've got our PQIP report, but the other important report that I would suggest you go and look at is highs and lows. So that was published in December of last year. It was run by NCPOD. It looked at 509 patients coming through for surgery in February and March of 2017. So actually similar timing to the first PQIP report. Only 35% of patients in that study had good care from both a clinical and an organizational point of view. 35% of patients needed should have had better care from a clinical point of view. Organizational, there were only 9 or 10%, but still that is a significant number of people did not have good care in the perioperative period. And as our college president said at the time, is that there's an enormous and unwarranted variation in the standard of care provided to patients having surgery. So we need to standardize care. And they produced an infographic, which I will summarize as standardize your pathways within your hospital, not within your specialty, but within your hospital. Look at the pathway overall and get it right across the board. Early optimization, and as we've already talked about, it needs to happen in primary care. It takes 3 months to adjust an HbA1c. If we're doing it with only 2 weeks to spare, it's not going to happen. So it's too late to influence outcomes if we're doing it at the last minute within a pre-assessment clinic. Avoid prolonged fasting. The more meals you miss, the worse you are, the more likely you are to have drug errors. Multidisciplinary working. The CPOD report noticed that diabetic specialist inpatient nurses and dietitians were very rarely involved, and multidisciplinary working makes a difference. And finally, communicate. Communicate to the surgeons, the ward staff, and to the patient. If you give a patient realistic expectations of what's going to happen to their diabetes, then most of them particularly type 1s, have the skills to sort that out. So where do we find the information for where are the standards we should be aiming for? This document is the most recent document available. It's the Joint British Societies of, I always get this wrong, Joint British Diabetes Societies for Inpatient Care. It's made up of dietitians, inpatient diabetes specialist nurses, diabetologists, and patient representatives via Diabetes UK. They give detailed things of every single step, which is this, you can see this is one of these things that we all nick for when we're talking about perioperative medicine. Every single step of the way is outlined of what we should be doing, and there's audit standards in that document telling you to give you standards that you can measure your care against. One particular bit in that is detailed information on preoperative medicines, because that's actually one of the main things that needs to happen to get the care right. So we start in pre-assessment. The main aim of pre-assessment is to get an individualized plan for the patient. Perioperative drug changes, fasting guidance. Let's face it, many of our patients don't realize that it's better to fast for shorter times. And then to identify the high-risk patients, those of us with type 1, and those with poor control. And the reason that little picture there is I can tell you from own experience of having surgery, modify patient anxiety about telling them what to do if they're hypo whilst nil by mouth. Glucojuice is a clear fluid. If you take one thing away, give them glucojuice to take when they're hypo. So an HbA of 8.9, 67 in new money, designates a problematic diabetic. And this is drawn from I'm going to turn away, so hopefully you can carry on. From an HbA1c, 8.5, you can actually infer the estimated average blood glucose. And this is the figure that I want you to look at, that it's 8.9, 10.9 is the average blood glucose of a patient with an HbA1c of 8.5, which means that they are potentially going to be, they're always running high compared with what you'd expect from normal physiology. And the other aspect of this is it shows that your range might be from here to here. Conversely, it could be here to here. So it gives you no real measure of how the patient's sugars run in reality. Thinking about 8.5, if you're up here, let's face it, I come across patients in my clinic with 10s. The worst I've had recently was 12. That means that they're going to be going from 20 plus to a low of 10. And we expect them to run from 6 to 12 during the perioperative period. I'm going to dip into newer drugs because I keep coming across these and I don't know what they are. And so I'm going to share my ignorance and a little bit of knowledge and actually how they might impact. So sodium glucose cotransporter 2 inhibitors, GLT2Is, these work in the kidney, promoting glycosuria. So from a perioperative point of view, if a patient is on these drugs, I perceive them as being potentially more hypovolemic when they present into surgery. And the other important thing about them is chucking all the sugar out into the urine turns off endogenous insulin working, and hence they're more likely to have a ketoacidosis, even in the presence of normal glucose. So this is a group of type 2s that are potentially risk of DKA. Can't pronounce this. DPP4I inhibitors. I was busy Googling it last night on how to pronounce it. It wasn't helping me. These work on gut hormones, incretins. So they stop incretin from being broken down. So what is incretin? It's something I was asking myself. So incretin is a gut hormone that promotes insulin secretion by the pancreas. It also decreases glucagon activation, so it promotes normoglycemia in that way. It also decreases stomach emptying, which means that the patient effectively gets a low GI meal from a high GI meal, glycemic index meal. These ones here work by actually just mimicking, rather than just breaking down the, stopping the breakdown of incretin by mimicking it. That's the one that we see patients having subcutaneously once a week. The advice at present is to stop all of these in the perioperative period. Though what you do quite about these when they're given a week ahead, I'm not quite sure. The other group of drugs that I've realized that non-diabetics don't know about are the analog insulins. So we're all brought up on Act Rapid, which is our nature identical. That's what they put into E. coli and churn out, and it's identical to what comes out of your pancreases. It doesn't act rapid. It takes about 2 hours to work to full effect. So for a convenience point of view, as a jobbing diabetic, to support them, they created what somebody once called wash-and-go insulins. So you've got ultra-short-acting and short-acting insulins. These are the ones that you'll find in your hospitals probably, which means you can take your insulin just before you eat. But from your perspective, those are the ones you just omit when you don't have a meal. So they are not going to be having any effect when you come across your patient on an operative day. It also means you can start them early. And then the longer-acting ones, these are the ones that we come across in type 2s and type 1s. These are the ones that we can carry on in the perioperative period, which gives safety for our patients, our type 1s, so that they always have insulin, and also gives that trickle in the background to make sure that the type 2s aren't going too high. And this graph shows the different times. I know we're not all anaesthetists, but we love a graph. And this is the point I want to make, is that the rapids work a lot quicker, but that they still have a significant tail off. So your patient has still got some insulin on board at 4 hours. So when you admit, do not change the route. I'm preaching to the converted here. We should not be changing the route because of their diabetes. But this might be something that people feel is a little bit more contentious. Type 1s don't get insulin resistance. They haven't got any. So if you give them a carbohydrate load, pre-op is about 60 grams of carb within one single shot. You will have a hyperglycemic patient on table if you don't give it with insulin. And this has actually been a cause of a critical incident within our institution because of hyperglycemia peri-op. And it's becoming recognized that an increasing number of type 2s are not just insulin resistant, they're insulin depleted. So within Guy's and St Thomas's, we've recently said that if they're on insulin, you should not have the carbohydrate loading drinks because they are causing more problems than they are saving. And then the overriding thing, this is what should not be happening. If we are going to get our patients dreaming, they should be eating not long afterwards. So there is no need for IV insulin infusions. The indication in the current guidance is nil by mouth for 12 hours or more, or missing more than one meal. Type 1 or all diabetics should be first on the list and getting that next. They shouldn't be nil by mouth for a prolonged period of time. But then if you're not going to put them on insulin intravenously, how are you going to manage them? And this is what we do in our institution. So we have a hyperglycemia guideline, which is currently working in our surgical admissions lounge for on-the-day admissions. If you're taking pictures, have it like that, so it's a bit bigger. And the slides will be coming out to you all. So it is managed by our nursing staff with subcutaneous insulin. And we feel it's safer because you get that tail. If you give IV insulin, it's gone within about half an hour at most. If you give subcutaneous insulin, and we use Nova Rapid, it's got a tail of about 4 hours. So your patient is covered and safe for a period of time afterwards. And that graph comes back again just to illustrate that point. So Nova Rapid is going on till here. But if you give IV, it would be peaking here and dropping off really quite quickly. Couldn't find a slide with it all in. Then, of course, you're going to have to deal with hypos. And we've decided that glucojuice is clear fluid, because it is. And as I know, Mike Swart has recently published a series of patients who had clear fluids up until the point of coming into the anaesthetic room. So we are using this, and personally, and I will hasten to add this is my personal view, I will anaesthetize a patient that has had glucojuice within the last half hour, because I know from using it from personal experience, there's no way it's sitting around in your stomach if it cures your hypo in 10 minutes flat. So these are available. The important thing for safety, the overriding safety rule, is that type 1 diabetics must have insulin. And this is a quote from one of my lovely diabetologist friends at St. Thomas's. The most conclusive way to find out if a patient is type 1 or type 2 is not to give them insulin. If they die, or I'll put a thing in there, if they go into DKA, they were type 1. And if you don't give your diabetics insulin, you have got the potential to give them a serious complication. So, brief dip into new technologies. The proportion of patients on pumps in the UK, 3% of patients in the UK are type 1, and of that, I remember a figure a little while ago, 3% of them are on pumps. But there is a push to get more and more people onto pumps. And the other things you're going to come across, that's a Dexcom, which is a continuous glucose monitoring. That one is the one that I'm lucky enough to have, which is a pump with another sensor there. But this is the one here that you're going to come across more and more often. And this is the Freestyle Libre. What it is it sits on the patient's arm and allows you to get their blood glucose. My dream is that we could make perioperative glucose monitoring so easy by just putting one of these on every one of our patients when they come through. But the cost has got to change. These things last for 14 days, and the cost implications and kit and so on is one of those things. But we don't do an anaesthetic without monitoring a patient's blood pressure. The NCPOD report found a significant number of patients did not have their blood glucose monitored during their surgery. I've done a local audit. My personal crusade at the moment is to get my colleagues measuring blood glucoses. 50% of the patients coming through our unit, with me ranting on about it, did not get blood glucoses done. If you don't know what it is, how are you going to treat it? So, my message is, hospital-wide guidelines. Don't do it area by area. Get one guideline in for the whole hospital. Then CPOD says that you should have a perioperative lead. Create an individualized plan for every patient and communicate it. I want to bring in a passport for the patient that they carry that is with them, which gives the plan and expectations. Avoid VRIII, what we used to call sliding scale. Give type 1s insulin and measure their blood glucose. And hopefully I've kept to time. So yes, this is what we're aiming for.